So thank you, Dr. Anzueto, for joining us. We're live here in Eagle Pass, Texas for the Eagle Pass Heroes Autism Convention. We're so lucky to have you. I've had the pleasure of meeting Dr. Anzueto in the Houston community. He is an outstanding behavioral developmental specialist. He works for UT Health. He does a huge number of things. He's been in the Houston area, I think a little bit under a year yet, but definitely building a great, huge reputation with our families and really providing them hope and resources when it comes to disabilities, especially within the autism. So Dr. Anzueto, if you want to go ahead and start your presentation, I'm going to mute it on my end. I'll monitor the chat. And before we get started real quick to Dr. Anzueto, because we do have some people tuning in that are Spanish speakers, I'm going to have Ms. Annabelle kind of introduce too as well real quick in Spanish.
Hola, buenos días. Primero que nada, muchísimas gracias, ¿verdad?, por habernos acompañado. Aquí les presentamos al doctor Gabriel Anzueto. Es muy buen doctor, está especializado en muchas cosas, es genial en lo que hace. Nada más que hoy le tocó trabajar fuera, por eso nos va a acompañar Zoom, ¿verdad? Esperemos que todo funcione. Es la primera que hacemos Zoom, vamos a ver cómo nos va, ¿ok?
Okay, thank you. And so would you want me to toggle between English and Spanish or just kind of?
I'm going to get a survey for the people in the room. Raise your hand if you prefer Spanish. English is preferred. English looks like it's the preferred language right now, Dr. Anzueto, so thank you.
Okay, again, you guys can tell me. I can answer any questions, both in English and in Spanish. I can toggle. Like I said, my main goal is really just to connect with everybody, and I wish I could be there. I love Eagle Pass and the food and everything, and the weather's a lot nicer. I'm in Washington, D.C., and it's cold and it's raining, and I've been stuck in the conference center all day. So yes, I would have loved to have been there, but we'll definitely make this work. So let me see from my end. You guys can see my slide. So like Wendy said, I'm the medical director of the neurodevelopmental program at the Duncan CLI Institute. That's here at the University of Texas in Houston. And I'm also an assistant professor and a regular man family endowed professor in neurology and developmental behavioral pediatrics at the McGovern School of Medicine. So for me, it's a really good pleasure to be here. Para mí es un placer estar con ustedes. Por favor, si alguna pregunta en español nos puede decir y con gusto le vamos a contestar, pero voy a hacer la presentación realmente en inglés. So my goal today is really to share a little bit of kind of what my story has been, what my experiences have been, because I think with our experiences and the theme today, what we bring in our experience is what we bring in life. No one really just wakes up and knows things. It's the people that we meet, the places that we live, the experiences for whatever reason that we encounter that really shape our perspective on things. And I think that comes hand in hand when it comes to culture and how do we see something like autism spectrum disorder in the lens of all of those perspectives. So again, I from Texas A&M, I'm from San Antonio, so I had a bachelor's degree in public health. And my first research was with seeing Mexican Americans with their health living in Central Texas and the same type of Mexicans living in Central Mexico and see how their health differed. So it was a good time to really get to know the Mexican American population and what challenges they had for healthcare. When I was in undergrad, I was an EMT, so that's me a lot younger with a lot more hair. And so I had a good time in the ambulance picking up sick people, learned a lot as well. And then I was able to go to the University of Texas to get a certificate of public health. And the certificate of public health, I really was able to understand not so much that in medicine, we really try to get you from having the disease to not having the disease anymore, but really get you to having the high wellness, to have a really high level of wellness. And when we talk about autism spectrum disorder, my big mantra, and I'll say it again, I tell parents again, this is not a disease. This is not a medical pathology, but it can cause both caregivers and even the individual to maybe sometimes fall to have other medical pathologies like anxiety, depression, ADHD, things like that we'll talk in some detail. So really bringing in the idea that wellness is important, and that is a goal as a medical provider, not just saying, okay, you're no longer sick enough to be in a hospital, you can just go home. And from there, I was able to go study medicine at the University Autónoma of Guadalajara, and what it was a great experience because in Mexico, especially this program, it was a big focus in going into the community. We went to people's homes. We understood kind of what their perspective was in healthcare, the culture between a physician, a doctor, a provider, a nurse, and the patient was really something that was just extraordinary and a great way of connecting and feeling mutual ownership and respect between both. And then what I did was I went ahead and I transferred to a school in the Caribbean so I could go to Chicago and finish my studies. When I was in Chicago, I did a residency in pediatrics at Cook County Hospital. And it's a community hospital, a public hospital, which we accept everybody that really will come through our door. And again, having the pleasure of seeing people from different types of cultures and backgrounds, those who speak English, those who were immigrants, and understanding their overall health pediatric care. And then I specialize in developmental and behavioral pediatrics at the University of Chicago, which is in the south side of Chicago, with a different type of patient population. And then I was at Lurie Children's Hospital at Northwestern for a couple of years between the pandemic hit. And then I was happy to finally be back in Texas, which was my goal, and at the University of Texas in Houston. So again, I shape a little bit with my background just to understand that at every location that I've been able to kind of understand and learn from people in my environment. I really do feel that my perspectives of my practice today, the way I manage my patients, I relate with my patients, would have been probably a little different if I didn't have that opportunity to live those different experiences in those different environments. So like Wendy said, I'm a developmental and behavioral pediatrician, and I know it's something that's possibly not known to a lot of people. I know there's not a lot of us, even in Texas. I am the only developmental behavioral pediatrician at the University of Texas in Houston. I'm the only one I think that speaks Spanish in all of the greater Houston area. There's some in Dallas. There's probably one or two in Austin. I think there's one now or two in San Antonio. So really in the U.S.-Mexico border, there's two colleagues that might be going to McAllen, but really for the amount of children that we have, we don't really have enough of us to really help out and to serve the community. And a group of senior developmental specialists wrote a paper in the Journal of Pediatrics, really explaining to the world what we did as developmental behavioral pediatricians, hopefully to raise awareness of kind of the things that people can seek us out for. And you can see that we really see a lot of range of kids. So things as, of course, autism spectrum disorder, kids with intellectual disability, issues with feeding, attention deficit hyperactivity disorder, kids with school problems. We're going to start a study in working with kids with spina bifida, kids with achondroplasia, trauma, so different types of things. So there's really is a vast array of patients that could really benefit from our services. So, and it being so little of us, it really is hard to kind of go with the day-to-day and be able to meet the need of the community. So for me personally, I've always had the need to self-reflect in working in a very busy, high-demand environment, that what is the most important thing when it comes to treating patients. And I think it's the act of the virtue of empathy. And empathy is bringing that empathy to our practice and seeing whatever type of patient that we see, whatever type of background they come from, or even the attitude maybe that the parent might bring to the visit. So again, empathy is an emotional experience, and it's one that it has to be very self-reflective on. It's a one-way street in terms of the one who is trying to be empathetic, who's working on empathy, is trying to find that emotional experience when observing a subject. So I'm observing this individual in my room. I'm observing this family cohort, these parents, these siblings, these maybe another grandparents with us. And I want to pick up on kind of what they're saying and even their body language, so that I can identify and then see, okay, let me sit on that side of the room with them and see what angle are they seeing something from. Because for me, they're my maybe last patient of the day. I see, like I said, a lot of patients during the week, and from one point it can seem like it's just another grind. Like this is just another patient who has a developmental delay, most likely, maybe, possibly has autism. We'll have to figure that out. But, you know, how do I kind of take myself to something more than just saying, okay, this is just not another kid I'm seeing, you know, how can I get myself to that emotional state? The emotional state really say, okay, you know, this is more than just a diagnosis that I'm about to talk about with this family. You know, we have this family who's entrusting their intimacy, right? And talking about things that probably they don't discuss with other people in the community. They are discussing possibly difficult personal relationships that they have, but ultimately they're entrusting me with their child or their children. And so that's where I really have to kind of take that act of empathy to understand that, okay, I need to not get into the mindset that this is just another one of my 300, 400 kids that I see a week. And that's very important because when it comes to autism, and it's probably already talked about, you know, in your great symposium, the prevalence numbers, the amount of kids with autism, the new numbers really show that it's something that is increasing. So more and more, we're going to see more children with the diagnostic question of is it autism or not. The numbers also of the CDC, so when they took at these numbers, they had about, I think it was 12 states in the US, so they didn't really look at every state. They looked at the majority of the states, well, these 12 states that they believed was a good representation of the country. And besides saying that the autism numbers are going up, for the first time, they reported that in terms of how many 8-year-olds have autism, more 8-year-olds that are Hispanic and African American are reported to have autism than they're non-Hispanic whites. So traditionally, Hispanics, most Mexican Americans, Hispanics, or anyone can say Latino based, were the ones that were being diagnosed later for whatever reason, or also that we know that there were more challenges that they had, but we weren't seeing them in practice. So this is something that really brings to light that autism is here and it's here to stay, and we're going to see more of it, and we just have to partner and figure out what to do with it and how to, again, support our families. But also most important is to understand that autism has different types of faces and different types of conditions that can co-occur with. One of my research interests that I'm working on right now is with a group of the Down Syndrome Medical Interest Group, where we're looking into differences between kids that have Down syndrome. We already know that Down syndrome itself is a big diagnosis. It's something that that children require a lot of specialized care. We have a special clinic at UT Houston that sees kids with Down syndrome. And besides just seeing kids in their medical conditions and helping their medical supports of Down syndrome, we also understand that they could also have the difference of autism. And that's important for them to be able to access high quality care and to live their best life. And again, if there's any questions or any comments, I would really don't mind to be interrupted. I like to be more of a conversation than just kind of me talking. So, si hay alguna pregunta o duda, me pueden interrumpir, por favor. Se los agradezco. So we can later then, we see that, okay, we have high numbers of autism and people always say, okay, what do I do with it? How do we treat it? Doctor, what's the medication? What's this? What's that? And that's an understanding because they come to a healthcare provider, they come to a physician, and I'm giving a medical diagnosis. It's natural to feel that we have a medical intervention. So, but intervention with autism are interesting because they really they can take on different faces and different approaches. So, of course, ABA therapy being an evidence-based intervention for kids with autism, we really push early screening and bringing this to the attention a lot earlier, because then we know that, you know, time is development. And when you're able to get that high quality therapy early, you really shape that brain and help make those good connections to minimize those signs and symptoms or those impairments we see in autism. Early childhood intervention. So again, besides ABA, there's no access to ABA can be challenging in certain places. The state has a program called Early Childhood Intervention. We'll talk about that in a little bit and have another way to access, you know, things like therapy, occupational therapy, and school support. Go ahead, Wendy.
What are some things, we have a lot of educators here with us today, and sometimes we've heard some feedback about parents not wanting to go through with the diagnosis. can you talk about the reasons why or the harm of not obtaining a medical diagnosis, the delay in that, what it can do?
Sorry, you were cutting out a little bit. So you said you had some educators that go ahead. I'm sorry about a diagnosis.
How can educators help encourage parents obtain a medical diagnosis? They have a hard time just in the schools getting them to accept an educational diagnosis for interventions, but we know that there's other things out there. So can you explain the importance of identification with identifying a disorder?
Yeah, definitely. That's a great question. So yes, definitely, it's important to have a medical touch-in for several reasons. First of all, I have to say I'm really impressed when I moved down to Texas that the school psychology teams and the school art teams really did a good due diligence in helping with diagnosing and bringing to light autism. In the public schools, in my experience in Illinois, even though they had a medical diagnosis of autism, it was difficult to even put it on their IEP. So that is something definitely an advantage, we see in Texas. So thank you for doing that. It makes our job a lot easier. We know that with autism, there are some medical co-occurring conditions that are important to bring to light. So for example, kids with autism, they have a higher rate of seizures compared to the general population. It's still not a 80% chance, but it's something that can be, higher than the general population. Kids with autism can have other underlying challenges. For example, if they're really, really picky eaters, I see a lot of kids with vitamin deficiencies, with iron deficiencies, a little bit of malnutrition. Their weight can be really high because, if you just pound a lot of calories, you're going to gain weight. But, getting enough protein, and especially when it comes to iron, because iron helps to build your hemoglobin, your red blood cells, which transport oxygen to your brain and even are something important for development. So from the medical end, I really screen for those issues. Some kids with autism continue to stick things into their mouth and mouth things, and they're a higher risk of lead poisoning. And lead is also a toxin that in high numbers can also be like a double whammy that's not helping with optimal brain development. Some kids can have an issue with their hearing. And so we really try to get hearing checked and vision checked. And also genetic testing is very important because it really is the next frontier in trying to understand what is the origin of this condition. There's some kids that we found, not a lot of kids, but a subset that they have a genetic condition that all we see is autism, but then in this genetic difference, they could be at higher risk to have a heart condition or to have trouble with their liver or trouble with their kidneys. So if we identify that is a medical issue they have, then we can right away start getting them treatment or at least being vigilant about it. So it is interesting because we are like stepping ourselves in two different worlds because like I tell people, autism, you're not sick. And we talk about that. It's not a disease, right? Not contagious, of course. But we know that it's a neurodevelopmental difference. It's a challenge with the wiring of your brain and the way the brain's making connections and what parts of the brain are lit up more than the other. Some kids have more complex medical issues, and some kids seem to have just autism spectrum disorder without any medical issues. So coming for a medical checkup will help figure out which kids need to be followed more closely and which kids just, need initial workup and to be followed every 6 months or yearly. It's a great question. And it comes to the use of medication. Like I said, there's no medication for autism, and we don't promote that there is a quick fix for autism. Currently, right now, it's just being used.
Hello. I just want to ask you if you can elaborate more about the metal toxicity in kids, like mercury and stuff like that, because I've been hearing a lot of that lately in kids with autism.
That's a good question. I hear that a lot too. There isn't really a connection that kids with autism have a metal toxicity. So there are some providers that will encourage mothers or kids with autism to get levels of heavy metals and things like that, and thinking that, oh, if you get a heavy level metal, we can get down. I would lean more that that's more of a myth to my understanding. So first of all, I consider myself a very open-minded person. I'll talk a little bit about, the gut microbiome and things like that. And there's even information on, there's research on CBD and things like that that are being done in an organized fashion. People have researched the theory that heavy metals cause autism. Yes, heavy metals can cause a danger in people's brains, especially like lead. But to say that every child that has autism has a heavy metal toxicity, I don't agree with that. That also comes a little bit with the camp that say, okay, a lot of the challenges with autism come from the vaccines and that we're injecting heavy metals into our kids, and that's why they have autism. I also that's been something that the person who first said that vaccines cause autism, that doctor was actually, he admitted to lying about it. He was a doctor in London. He got kicked out of London. And they retracted that paper he wrote. So, but he's still in the U.S. spreading the rumor that vaccines cause autism. The vaccines themselves are cleaner. When I was growing up, the vaccines were dirtier. They had more metals and they're pure. But when people tell me that, I have a child and my child had a vaccine and after the vaccine had signs and symptoms of autism, I do believe them, because I see that with a lot of things, not just vaccines. I see that with, my child had a diarrhea, my child got the flu, my child fell and broke their arm, my child had a cough, had an ear infection. And after that, it just seemed that from there, they were having autism symptoms. So I think what happens in that
child has a regression because I don't know, I think these kids with early signs of autism since 12 months, right? And my child, it did not. He had normal abilities like speech, like 5-10 words at 12 months, and everything, like a neurotypical kid. And then he lose all his abilities. He has gained some of it now through therapy, but that's something that nobody, no research can, they don't have any information about regressions.
So yeah, there's a lot of people that are studying regression in autism, and what is being understood now is that autism has a genetic origin. It's something that is genetically in their DNA since they're growing in the mother's tummy, and that our genes have clocks in them, and there's something called epigenetics where genes can be turned on and turned off. Sometimes they turn on with age, so you might hear that, I have a cancer gene that for breast cancer, that it's probably not going to affect me till I'm 40, 50, 60, But you say, if I have it now and I'm 20, why don't I have breast cancer right now? Because we're learning that these genes can be turned on. They can be called methylated. So our theory with regression is that there's a subset of kids with autism, that there's an inflammatory response. So inflammation from whatever source it's coming from. Like I said, a flu gives inflammation. When you get a vaccine, you get inflammation. When you get a stomach bug, you get inflammation. Or coming with the microbiome, we're understanding that the gut bacteria and the brain can affect the social functioning. So the gene to have that regression, we believe, was always there, and it was just waiting to be turned on. And that's a very common situation that we see. And again, that's why we do genetic testing to see if there's a known genetic difference that cause that gene to happen that way, and continue to follow and see how they're going. We also test for seizures. Sometimes some kids have subtle seizures, and that's why with the regression, sometimes they don't. The majority do not. So that's something where a medical checkup is important. So yeah, thank you for sharing that. And when it comes to the microbiome, we understand that when we looked at mice with autism symptoms, the bacteria in the intestine of those mice was different. Okay, and it was different than those who did not have autism. And when basically they transferred the bacteria in the intestine and the gut into the mouse with autism, they improved. And so there was a small study that had 18 children with autism. They were given a specific concentration of probiotics, and they had 80% of improvement of their GI symptoms. So sometimes these kids with autism have bad issues with constipation. We definitely have issues with picky feeding, and we don't know if that picky eating, because of lack of language, is also due to maybe they ate something, they felt like a cólico, it just didn't feel right, it didn't sit well in their stomach, and they can't tell us, oh, mommy, you know, that bread, I don't like it. It makes my stomach feel funny. They might just refuse it, and that's why maybe possibly a subset of picky eating is because of issues with the gut microbiome. And so the important thing is that there's studies currently going, especially at the University of Texas in Houston, that they are recruiting kids with autism and kids that have some type of GI upset, so constipation or issues with picky eating, and they're giving them pharmacological grade probiotics. So I have a lot of patients that use all over-the-counter probiotics, and they say it helps, they say it doesn't help. The issue with over-the-counter is that it's not regulated. So they can say this has this, but really they don't have to have that dose for what's on the label. It's something that it can be a hit or miss. There's higher quality ones, but also it could be depending on the child's bacteria type. So that's still very new in the issue with probiotics and with autism. Excuse me. But just to know that there's a study, there's people that are interested in using pharmacological grade, so where you know the dose of the probiotic is consistent, and the experiment is what dose is the right dose to help improve behavior, especially aggressive behaviors in kids that have autism. Because there is this connection between this mind and the gut. And that is where I also come back to inflammation. So we don't know if, because of the type of gut bacteria that we have, because of that bacteria that's growing already, maybe it comes from a genetic origin that our bacteria is different in kids with autism, or does it change over time? That's something that it's a big question mark. How can that can cause microinflammation, something called leaky gut, and that can also affect the central nervous system and the brain. So another theory when it comes, because I have a lot of patients who, because of concerns for autism, do not get vaccinated. They say, you know, we're going to wait. We're not against vaccination. You know, I just have this innate concern. And I, like so, I'm the person that I respect everybody. I'm not going to, you know, say you're crazy or say go away because you don't want to vaccinate your child. You know, I'll be open because I'm empathetic and want to understand where you're coming from. But I do have a subset of kids who do not get vaccinated and do have regression. And it happens a lot between the 18 months and 24 months. So again, it comes back to the theory that these genes are already programmed. So to say, you already have the recipe to have autism in your genes, but it doesn't get turned on until later on. Some kids get turned on very easily. There's never a regression. Some parents say as a baby, they always were a very quiet baby. Or also I have some patients who say, you know, my kid was neurotypical and then they regressed. And I ask, okay, when they were about 9 months, were they easy to go with somebody? Did they cry when they separated from mom? You know, were they the easiest one to have anybody come and visit them? So sometimes, not all the time, sometimes there's some subtle developmental communication milestones that are not met. Because when you are a young infant, even before you start talking, there are milestones for communication. Sometimes those kids with regression also have some delays as well. So it's a big attention for some colleagues. Like I say, so I'm in Washington right now at a big pediatric academic conference, and there are people that are studying regression, and people from Boston Children's and Harvard, and people. So It's something that we're interested in to understand a lot more and why there's some kids that have it and don't have it. But that's the type of intervention that we have that's going on. But then also, the biggest important thing that I always feel and that I like to focus on in kids with autism is how do we improve communication? And there's a subset of kids who need a lot of different help, a lot more help in getting that. And we use things like assistive technology and also traditionally something that's called an augmentative and alternative communication. So for all those in the room, can you tell me, what is assistive technology? Does anybody know what that is?
Yes. Oh, they're just raising hands. I was like waiting for examples. So I know like there's low tech and high tech assistive technology. I use a lot of low tech assistive technology with Post-it notes around my house to help remind me to do things.
Mm-hmm. Yeah, definitely. And like I said, I think, I'm in a room with a lot of good educated and individuals, but when we were really trying to understand when I was telling kids, especially not to Chicago, explaining to parents, hey, let's do technology. They're like, what do you mean? What's this? And then I understood, okay, how much do we know what technology is? And that's also when it comes to understanding someone's background and having empathy, maybe because when we study something so much, it just comes very natural. It's like when people say, oh, you're bilingual, that's so easy, or that must be so hard. And I can say, it was easy. That's not true because, like I said, my mom forced me, and so I learned and I was exposed. So I can't say it's easy for me because I know it, right? So what is the perspective of other people? So when we were in Chicago, I was able to do an intervention where we went out and we wanted to figure out what was the knowledge and the education of those, Latinos with disabilities that knew about this technology, and not so much so for communication devices, also things like wheelchair use and things like that. So this is a younger version of me with two other PhD candidates from the University of Illinois in Chicago. They're bilingual, and we work through an organization called LEND. So LEND is Leadership, Education, and Neurodevelopmental Related Disabilities. It's a great program. I participated in it when I was in my fellowship training in Chicago. Here at UT Houston, we do have a LEND cohort, and there are another one in Austin. So especially, the parents are the driving force of our specialty. I think they bring a drive that no one else does. Definitely, it's something where you can participate in, hopefully from a distance. It's something that could be something possible to do. So the objective of our issue was our plan was to go out in the community and see in Chicago who understands what's going on. What are your knowledge about assistive technology? What kind of support system does a Latino with disability have currently in the Chicago area? Because what we brought with our knowledge was that we knew that Latinos, they're the largest minority group in the United States. And in Chicago, at that time, was about 30%. I think it even grew a lot more. And then a major barrier to Latino seeking assistance services, were just also the language. And there wasn't really a little bit of research that talked about kind of issues with graphing technology or assistive technology. So like Wendy was saying, this is low-tech communication technology where we have communication boards. And we want to understand when it comes to language communication, I really try to educate parents not to be afraid to use things like pictures. Sometimes parents feel that we are kind of dumbing things down or that we are giving up on expressive language. But we take for granted that we are so used to communicating with words that we think that the only way we can communicate is by a spoken language. So this is really opens up using the strength of the child. So the child with autism, the little children that have been scanned, have had functional MRIs, they've seen that compared to kids without autism, the parts of their brain that uses their visual processing is super lit up. Like it is even more powerful than a child without autism. They have a super ability to look at things visually. So this allows them to use their strength and teach them something that is just doesn't come merely natural to them, but something that they can also learn. So then this is high tech where you can go to a communication device, so same type of pictures, and you can, create a sentence and go out and do things like that. And also if you're a wheelchair user, you're able to adapt the wheelchair joystick to be able to go and use technology. So definitely a cool way to have different types of use of technology. And in the world of the technology, I really got sold on really pushing for this type of assistance because there's a documentary that's called Deej. And Deej is a young boy with nonverbal autism that was adopted when he's about 6 years old. With this type of technology, we have this boy, his name is Deej, and if you see this child walking down the street, and if I asked you, would you believe me that this child graduated from college? And a lot of times the people will say, no, because I don't think they have the ability to even speak. It was based on a technology like this is the technology that this child in this documentary, Deej, was able to go to college and even write poetry about his experiences as a child when he was growing up in foster homes and things like that. So really, it is a really, really good documentary that I recommend. So what we did was that, basically we had an outreach program where we went to go, we talked to the community. And most importantly, what we talked about, a lot of the individuals did not understand what AT was, what such a technology was. There's a huge gap in just the knowledge. And they were really happy for us to go and teach these classes at different community sites and educate them. But also what really troubled me the most as a physician and a doctor in training was that there was the doctor that was not also being an advocate for this type of technology, that there is a gap in these individuals also teaching to the parents and the family members about technology, licensed technology. With the ones who did have the technology, they felt that it really improved their lifestyle, and also that they felt that it really improved their quality of life. And what I love most about this opportunity was that we were able to hear from those individuals, hear from the family, and they will say, I have trouble getting the technology because those who assist us are not well trained. And a lot of times in medicine, when things don't happen, we give a recommendation, do this, do that, and they come back and they haven't done it, we might judge them and say, gosh, why didn't his mom go get that service? I told her that's part of the recommendation. Why didn't she do this? Why didn't she do that? And we saw that these are these barriers that these individuals are telling us about. So we say, hey, go to the state website. They have all the information there, and they tell us, well, you know what? They always kept denying my stuff. It's difficult to find it online, or I can't navigate what it is to be something online, or it's just too expensive. Yeah, they gave it to me, but I'm not able to use it. It's too expensive. And also, they say that the centers that they have these services are very busy, and it's not something that it really is access. So when we look at these barriers and when we hear what people are telling us, it really makes us say, okay, we have this great technology and just people are really having trouble accessing it. Why is it more with this type of population though? So then quickly we just did another group where we wanted to sit down and talk about kids with just again with the caregivers and understanding what are your barriers to having access to technology? What are you experiencing personally? And what we did was we were able to do a qualitative research study where we captured the opinions in a semi-structured interview way and talked to parents and say, you have a child with autism, you have a child with that, their verbal ability is not the strongest. They could benefit from this information. Where is the issues? Where are the challenges? And we talked about different types of topics that we did. And we did what we call a semi-structured interview, where it's a really cool way that we can have a conversation face to face. It can go different ways, but also I have a goal, I have a target. So I have things I want to talk about, but I'm open for that person to share something that maybe I didn't think about, or a barrier that they teach me about. So we'll really kind of give a voice to the individuals and the parents, even though it was a very small group of parents, because it takes a long time to do this type of research. They love just being able to say, someone's listening to me. So this is just an example of what we call our protocol. So we had questions we wanted to give them and then probes in case we didn't really quite get what we wanted from that question. We're able to kind of guide them a little bit. We recorded these conversations and then we ended up coding and going through line by line of each conversation and really trying to highlight themes and highlight things that they've been telling us to get an idea of, where are these questions going? What directions are they going? And we have to understand also, based on what they say, who are we talking to? And we're talking to the majority of people that, caregivers that are stay at home or temp workers, but that their household income is quite under the poverty line. So not only are we having difficulties with the language, but also where are they on the socioeconomic status? And the major themes that we learned from interviewing these families was that, there's a lot of difficulty when accessing services with Medicaid. Medicaid is supposed to be, like I said, in theory, this kind of safety net, an ability to open up resources, but it's really made things a little more complicated. And because I think it's issues from both ends, and I think also there's issues with also what the holder of the Medicaid knows about how to use it. There's also some challenges with the primary care doctor in terms of their care coordination. Again, thinking that are we not educated, the doctors, the nurse practitioners that are seeing these kids in a general pediatric clinic, that they know that they can also talk about these things to their patients. And there's also problems obtaining the devices through the school education system, in Illinois. I don't know what it is, how it is in Texas, but like I said, in theory, part of the our process or the Americans with Disability Act is to give them the ability to have whatever barrier they need to communicate. Some school districts, I'm experienced, I don't know how much here in Texas, but Illinois, that they would have a device that would be owned by the district, but that they would use it in school to help augment their communication, and sometimes you could take it home to practice it at home. And then most important thing is that what's the caregiver's stress? Their immigration status, their challenges with the limited English proficiency, and also the supports they felt at home. And lastly, how do we access those services that we already know that are there for them, like SSI, that can help supplement and open up to more services? So let me just talk a little bit quickly about some things that were shared by these individuals. So in terms of immigration status, a parent told me that they get scared because of the way things are. And this was probably about maybe 2019, early 2020. Sometimes I hear on the news that if you're not from here and ask for help from the government, you can get deported. So the parental fear was the biggest barrier for accessing care for their child. Care coordination was a problem, where they felt that they were told by the pediatrician, your child's not going to speak, forget about it, forget it, live with it, come to peace with it, move on. Where they maybe searched some other subspecialists who said, okay, yeah, no, I think you could talk, but I don't know how you could do it. So they really were getting mixed messages from their providers. And also the challenge with coordinating with their PCP. They felt this parent, I remember, just kept saying how they felt that they were just another number. They had issues getting the attention of the provider, and they felt they were just one other patient in the thousands of patients that they have. So we learned that they described systematic government, educational, and personal barriers in attempting to access these challenges for their kids. And they also reported challenges in receiving care coordination through their PCP. And they also had issues with kind of the physicians' challenges of belief in how to address access issues. So I really took away saying how wonderful is having this great technology if it cannot be used, equitably. It's like, and what's the point then? Why are we using so much research dollars? We can have more focus on access and get this to the hand of people that need it.
Dr. Anzueto, I think that's kind of the theme when we're here in Eagle Pass. We're like, that sounds great, but how are we going to get it and access it? And we see it a lot, even just with the we have a lack of providers, and especially in this area too, it's every specialty care is out of a 2.5 hour drive. So it's pretty intense.
Yeah, it is. And, you know, I think there's great ways that we can work with that. I think Wendy, you were part of doing some things with Lend and how to, you know, improve access with education and helping with ECHO as well and things like that. There's other projects out there that could help, but you're right. I still trying to get on providers and how to disseminate those that it can get to the hands of the child. So that's why it's so important. We're not talking about culture, it's all about the perception of things. And when we, for example, again, say, I have all this list of stuff that you can do, where you're not doing it, we're getting better and saying, okay, you're not doing it. Let's not focus on blaming the parent or the patient. Let's take a step back and say, what is the environment like? You know, what's going on? There's always has to be a type of barrier. It could be systemic, it could be personal. And that's something where, you know, I bring my experience throughout the years and what we've learned. So in working with different, as a male, so when I was studying pediatrics at Cook County, there were 10 of us, and I was the only male doctor, and I was a 9 female doctor, so I was definitely outnumbered. And so but they were a great group. Also with my patients, a lot of times, you know, I would be the only male in the room, and I remember opportunities where I was with an Orthodox Jewish mother or a Muslim mother, where innately I go in, I shake everyone's hand. They respectively said, you know, I'm sorry, I don't shake another man's hand. And so they were able to understand, okay, so you know, the cultural differences being a male, in what seems to be a space where there's a lot of females that are professionals. And different clinicians can also, I felt, can interpret a caregiver's words differently, and it goes about perception. And I encountered this several times when I was in Chicago, and sometimes when I'm here, is when I have parents say, you know what, I feel that my child is a cross I'm a spare, and we hear that, and it depends who we're hearing it from, it gets interpreted differently. So being a practicing Catholic, I can understand where they're coming from, but my other providers or students could be like, wow, you know, I'm worried about that mom, maybe, or this caregiver does not feel attached to their child. They feel like it's a separation. They feel like, oh, my child's just a burden. And, you know, maybe, but the mom is something's wrong with her, things like that. And so when we perceive that, as one might see it as a sign of strength, we're saying you are finding strength in your faith and finding strength in other aspects of your life to deal with something that it's quite difficult. Others might perceive as, you know, you're probably maybe on the path of neglecting your child to an extreme like that. And then we always felt that it's always nice to make these connections with other people and knowing simple things like how to say hello and how to greet others in different languages. It really shapes the mood in the room when it comes to kind of, you know, trying to make a connection, any type of small connection with the families. But most importantly, when it comes to the Latino population and the Spanish-speaking population, Mexican-American population, and even my friends that I see and patients I see a lot of kids from Mexico, from Latin America, either through the phone or they travel. It's the community perception of what it is to have a child with a disability or a diagnosis. I remember so well that I had and this has happened about 4 times already, that families from India, when we talk about a diagnosis, we talk about autism, they keep saying that, how do I avoid being on the list? And I say, what list? You know, there's a list. There's a list where if your child has autism, you get on a list, and that list is used by people. I get different explanations about it. So in that culture, there is this kind of perception that there's a list, the secret list of all those, and once they cross-match that list, I don't know where they're education or for work, but there's this fear that I'm going to be hunted down or isolated. I had a family from Ethiopia now to Chicago that said, you know, kids with autism, we don't mesh. They are either outliers or some extreme possessed. They're not clean. So I feel like I'm going to be isolated from my community, you know, my small community here in Chicago because of my African beliefs or Ethiopian beliefs. And I've seen that with other types of sub-African continent beliefs as well. So what I hear a lot from the Mexican American, Hispanic, Spanish speaking population is the child is sick. That giving a disability diagnosis is saying my child is sick. Está enfermito, you know, and that perceives the negativity aspect of it. Or might say, you know what, that means because they're sick, there's no future. Or I can't even discuss school. Don't talk to you about joining a team or being part of the community or doing anything with another child because my child's sick. And I have to isolate them. And there's been a lot of families, especially kids with like Down syndrome, where in Latin America even, or some, they're isolated and they don't leave the house. And possibly they have great abilities to do things. I have kids with Down syndrome. You know, there's a girl with Down syndrome from Guatemala who studied in Spain, and she's a fashion designer. And she's been at the Paris fashion show. And then her parents have an organization in Guatemala called Margarita Tejada. And it's a organization that takes kids with Down syndrome from 6 months old and really gives them something that systemically and culturally it's not quite there yet, an opportunity to see what are your abilities without just assuming, oh, you have a diagnosis, I assume you can't do it. So that's what comes with the perception of sick. So I always, even though when I'm not told, I always say to your family, the most important thing, if you don't listen to anything from this very long day that we spent together, is that your child is not sick. And yes, you come see a doctor, but think of me as a different type of doctor, and like more like a wellness, we can say, doctor. And that's why I take that experience from that health, longitudinal range, that is not so much that I don't want you to be sick to not sick, but be not sick to how to live your full wellness. I hear a lot that it's something that I did, the mothers tell me. I failed to protect my child. I am at fault. And that's something I always assume. I've learned, and I'm happy to hear when they're like, oh, no, I know. But unfortunately, about 90%, I get a nod. And then I stop and I say, I know you can read all the rest of the things I'm going to tell you. Let's discuss this today. Let's leave today understanding why you as his mother or her mother is not at fault, why you didn't do anything to have this. And we break it down. And sometimes it can be broken down at a visit. Sometimes it's something that we have a longitudinal goal. And it could be something systemic. And a lot of times it comes from our innate machismo, where you come home and the children is the mother's responsibility. And we'll talk a little bit about positive parenting at the end and how development can really, shape that in terms of positive parenting. But it's just thought that, okay, I'm in control solely of a mother and the mothers are being blamed. Unfortunately, the roots of this go back to the 40s and 50s. There's a really great movie called I'm blanking, but she is the artist. She writes a lot of books. Temple Grandin. So Temple is a good movie on HBO, and I'm not getting any money for giving this plug, but it's a great perspective where a doctor told Temple's mother in the 1930s that, you know what, your child has autism. Why don't we stick her in an institution? Let's hospitalize her because she can't amount to anything. And today you have a PhD trained professor in agricultural science who had a mother who did not believe the doctor at the time and said, no, I'm going to work with my child. We'll figure this out. And that lingers, of course, still a little bit today, where but first the term helicopter mom or refrigerator mom was very common, that autism was caused because of a parenting issue. It was mom parented that parent correctly. So as those things still linger, I always make it a point that we really try to emphasize that this is nothing a mother could have done. Also, unfortunately, sometimes it is that mother who is the driver getting an answer and follows her heart. And again, I'm not dogging any dads. I'm a dad and I'm all pro dad, but sometimes it's just something that a connection that a mother can have with her son or her daughter that knew something is not right. You know, their mother says, don't worry about it. It's okay. They tell me, la suegra says, it's fine. You know, my husband was like that. He didn't speak till he was 8 or something like that. You know, don't worry about it. Don't go. They're going to do something scary to your child. I hear a lot that I get a child who's 2.5 or 3 and say, okay, I know it's too early to diagnose autism, but I need you to tell me what's going on. And then I say, pause. It's not too early to diagnose autism. We can diagnose autism as younger as 12 months. And so with the use of the ADOS, especially the toddler ADOS, and this other conversation, and especially at 3, it's not too early to diagnose autism. But then parents feel that they come with resistance because they don't come with a group, or they come with a cousin, a random person says, this is the person who only one that believes me. No one else does. And he or she are supporting me. And today I'm saying, doctor, something is wrong with my child. We need to figure it out. And so that is also very stressing for the child, because then they leave and they, again, are alone in trying to explain it to their caregivers, to their family, to their cohort, to their nucleus, to their household. So we're able to use things like telemedicine, and I offer the ability to have that conversation with dad, with caregivers, or help facilitate the conversation for that the mother does not feel that it's a burden all on them. And as we go through what I call a mourning process, where a lot of parents I know understand and feel that their child has autism, they've looked things up and they've seen videos. There's a lot of good resources out there that explain neurotypical development and challenges with communication. And they just need, the confirmation. So there's a mourning period that I understand that parents go through. So it's really trying to figure that out and tailor make it with everybody, it's quite difficult because, again, it's all about what everyone's experience in their household is. There's clinician barriers, and it's really frustrating when first of all, I feel that I have to really disrupt an intimate relationship between a mother, a family, and their provider, their doctor or their pediatrician or their nurse practitioner. Because the whole point of being followed in a medical home is that you gain this trust that you see someone since the birth of your child, and that person can grow with your child. So I hear a lot that, again, I'm here against the will of my doctor. I referred myself, or my doctor maybe said, I'm tired of you hearing me. This is going on. Here's a referral. Go away. Or fine, we'll refer. And then they say, the doctor says, he does not have autism. So I have to really be sensitive and say, you know what, I don't know the provider, and I have to respectfully disagree. And this is the reasons why, this, and this. I have had a few, 90% of the people leave pretty upset with the provider and swear they're going to change and stuff like that. So it really makes me feel uncomfortable because, again, as a clinician, I know that relationship with the patient is really important, but we really have to not be doing over reassurance. When we training our pediatric residents, and when I train my nurse practitioners, especially those who do community work, I say, you need to have a low threshold in saying, go get it checked out. What's the worst I can say? They get evaluation by speech and they say, no, everything's okay. Let's monitor. It really is not that invasive. There's really no side effect with getting a developmental evaluation. I'm not, think you might have cancer and I'm going to poke you with a lot of needles and see if I'm correct because I'm not sure. No, I'm saying your child is at this age and we're not doing this. And also it's very important to understand that the male development is in line with the female development. So having this perception of, oh, let's wait because it's a boy, very, very common in our culture. In practice, yes, we do see that there might be later talkers, but with the new CDC guidelines that we'll talk about in a little bit, what they tried to emphasize was that, sure, you can have some boys that talk later, but you shouldn't be 24 months, shouldn't be 2 years old and have no words. That's where we draw the line. Okay, yes, maybe A boy at 2 months, at 2 years, maybe it's just very simple, more milk, I want, and maybe a girl at 2 years is maybe speaking a little bit ahead, but they're both not delayed. Okay, so that's really important to understand. Also very important is that if you expose your child to 2 languages, that is not a reason why they are delayed in language. So being bilingual is not an excuse or not a reason for delayed in language, especially for me being bilingual and understanding that when you speak a native language like Spanish and your family member speaks Spanish, it's isolating, or you as a caregiver does not only speak Spanish, it's isolating to say, now I have to speak another language to my kids that I don't even know. Yes, English is an easier language to learn, but we know there's a lot of research that shows that kids can even learn up to 5 languages before the age of 3. If you have a delay in any language, you're going to have a delay. And teaching 2 languages are not going to make that delay worse. You might confuse words or have a sentence, todo pocho, right? English, Spanish, English, Spanish, English, Spanish. That could be the atypical thing for a bilingual child. And then we work on how to do everything in English or everything in Spanish. And then we really try to work on empowering the parental concerns, again, stressing the importance of surveillance with our residents and the students, and the importance on how to say, you know what, I think we're kind of behind on this. And I want you to go, call ECI, let's get an evaluation. I know they're only a year old, but they're not looking at you, they're not babbling, let's just get things, checked out as young as 1 year old. And it's just an evaluation from a professional in development that can come to your home. And we talked about the myth and the delay in boys. So the milestones for the CDC have changed, and they changed with wanting to really improve how to get a lot more evidence and maybe stretching things out for that when we do say you are delayed, you truly, truly are delayed. So in the past, when there was a milestone, it was because 50% of the kids were not meeting it. So it was tough because there was another 50% that could catch up later. And that's why watching and waiting happened, because practice would say, okay, you could catch up. Now these milestones push it to say, okay, if we say that a child should be doing this or this at this time, it's because 70% of kids should be doing it. So the majority of kids are doing it now. So that's where we're more confident to say this is a delay because it's been stretched out. Because of time, I'm not going through the milestones. It's something you can find. There's a milestones tracker. But if there are any questions on milestones, I can take them, no problem.
Dr. Anzueto, on the milestones tracker, if y'all don't have it, they have an app that they just came out with on Androids and the iPhone store that you can download, and you can easily track in English or in Spanish developmental milestones. It's a great free resource to have.
Yes, definitely. And it also, what's important with the milestones is to understand to use those milestones as a bridge to understand how to parent and understand the challenges when it comes to parenting. And I want to conclude today our time together to talk about positive parenting, because again, it's very common in our culture in that we have to pursue a dominance over our children and thinking that that dominance improves their behavior. And because of that dominance, they're going to change their behavior. Fortunately or unfortunately, behavior in kids and punishment has been really well studied, and we'll talk about that a little bit. And I can share some information where you can go. But again, we don't know what we don't know. So I really try to express to the parents to hit the reset button. Not so much think of how things happened in the past, but how can I use today's information and go off? So it's kind of like saying, stop using a roll and film camera and get yourself a digital camera. So get with the times. even though you used that when you were a child, let's get with the times. A great tool to help is called behaviorchecker.org. It is free. It comes both English and Spanish. And you put in any type of behavior and it helps. The only caveat it could be that I've been reading a lot of behaviors, like for example, like biting. And some of the behaviors I think can be depending where they are developmentally. And that's what you have to understand as well. When it comes to communication, it's not just what you speak, but it's how you listen to the words that are spoken to you. So you're very common that when you have a delay in speech, you also have what we call a delay in expressive and receptive language. People tell me all the time, "Tan necio." They don't respect me because I know they can hear, because I put on Coco Melon, they're all onto that. I open a bag of chips, they come running, but I tell them instructions, they don't listen. They don't follow my instructions. They don't do this. They run in the street. They do that. They're deceiving me as a parent. They don't respect me as their parent. So it's when we really have to educate and say, okay, receptive language is talking about how do you follow simple directions. And it's very common that you have an issue with receptive language. So from the milestones, at least by 2, a child with typical communication development will be able to follow a step command without using a gesture. So, instead of saying, pick that up and pointing, to say, bring me your shoes. They should be able to get the shoes and bring them to mom. Follow those commands. Pick up, put the toys in the bin, to follow those steps. When we're 2 and we're not even following a direction with a point, it's really perceiving that behavior and not to say, oh, okay, yeah, they're being defiant. They don't want to listen to me. I know they're not deaf. I got to ramp it up because they don't respect me. You have to understand that that's a receptive language concern, receptive mental delay. That's why we are really, really into getting the notion of having no hit zones, especially no hit zones when it comes to parenting kids and parenting kids with disabilities. Unfortunately, I have to call, so when I was in Chicago, I worked in the ER as well when I was training. So a lot of my kids with disabilities would come in very, very injured. Some with brain damage just because of the way they were being disciplined. A lot of these kids have high pain thresholds. So when you get hit, they don't react. So sometimes we feel that if I hit a child and they react, it's successful, that they stopped what they're doing. So that's my goal. Sometimes these kids have such a high pain threshold, they don't stop. So I think I have to hit more, and we see that the injuries can occur. There's a lot of evidence, and it's just astronomical that spanking actually shrinks the brain. And this goes a lot with you might hear about things called adverse childhood experiences, or ACEs. We understand that when there's a lot of stress hormones that are being produced at a very young age, less than 5 years old, it actually affects the development of the brain. It actually halts. The child is in a fight or flight panic mode the entire time, and the brain cannot develop appropriately. There's been a bunch of studies that show that thinking is harmful. It can show to lower IQ. There is no study that say if you want to change a behavior, spanking will change that behavior. What happens? Yeah, it could stop a behavior. But then I ask parents all the time very openly, do you think it's working? And the majority say no. But that's what we do. That's part of, I got you, especially on Sunday in front of everybody. Because I got people say, hey, you got to spank them. You got to put them in line. You got to show them who's boss. When it comes to shaping development and behavior, you can definitely have expectations, rules. Yes, there's no ice cream for breakfast, but we can communicate that in a different way that we can actually shape that behavior or keep our authority, so to say, in limiting those behaviors, and we don't have to be forceful. And again, it's something where we work a lot. Unfortunately, I know that from a legal standpoint, the laws are kind of tricky, especially here in Texas. I know in Illinois, if there was a physical mark left on the body, even though it was done by a parent, it was considered child abuse. But Here, I know there's a little bit more leeway, but unfortunately, if you have a child that's in the hospital with multiple broken bones or with brain damage or a shaken baby, things like that, then that can be an issue. So again, the whole point is really try to say as a parent, you can have your goals. It's not an excuse that because you have autism or you are delayed in language that you get a free pass. And that's where we also shape a lot about, and that's a whole other talk, and how to shape behaviors, things like that, not to use food and whatever. But it's saying that you need to get professionals like ABA therapists that can help shape that behavior in the way of using their strengths. You cannot teach it to them by spanking or by talking to them. People say, I explain to them I hear it all the time. When they're like, I told you not to run in the street because you're going to get hit by a car. It's like peanuts. For them, all they hear is wah, 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 wah. They don't hear anything because they don't have that developmental capability to understand what you're trying to say. And sometimes as a parent, you don't need to make any explanation. You're the parent. You have the power. And you just say, you pick them up and say, we're not, I'm carrying you now across the street. End of story. They can tamper, they can tangle, but I'm being the parent and I can control the situation. Nope, you cannot play with that knife. It's going to hurt you, cry all you want, whatever. I'm not going to explain how you're going to cut yourself because you're not that developmental level. Okay, so like I said, there's a whole other conversation, but that's all I had prepared for today. My main goal was definitely to know that this is an interesting topic, and because of just the difficulty with getting professionals in the field to reach your area, I was really happy when Wendy invited me, and unfortunately wasn't able to come in person because of my other conflict I have this weekend, but I'm happy to take any questions.
Thank you, Dr. Anzueto, and thank you so much for joining in with us, especially during a busy week. I wanted to read something I got in through the chat. It was when you were presenting earlier that her son's 3 years old and she's noticed behavioral issues with him increasing due to his gut health, and that he struggles with constipation. But when she gives him probiotics, she notices a difference, but she would like to know more about how to receive, I guess, pharmaceutical grade probiotics.
So there really is, that's what we're working on.
Okay.
That's part of this study.
And
is to be able to, what?
Is that study currently open right now?
So yes and no. I will encourage, you can, let me see if I have the phone number here, but I do encourage everyone, give me 1 second. I will go ahead and see, let me pull up, I think I have the phone number.
Okay. Because it looks like we have a
handful
handful of parents here that would be very interested in signing up and some of that stuff.
Yeah, so their criteria is that, of course, child with autism behavior issues, but also looking into the GI issues. So GIs are very, very common. I believe parents, when they tell me, you know what, I don't, they're on gluten-free, casein-free. They never had diarrhea, but the behaviors change. And there are a subset of kids that have a sensitivity to gluten and to casein, more gluten that I saw. And if you can have someone that can help you, and especially now it's a lot easier to be gluten-free just because of all the, it's everywhere in the supermarket and things like that. So I tell parents, if you want to try it, try it. And a lot of them do change the behavior.
Okay. We'll definitely look in that. Are there any other questions here live in there? Do you want to come up here? Get up. Yes. They're in the slides. I'll email it out to y'all too. So you have that. Yes. They really like your behavior tracker that you had.
Oh, thank you. I had nothing to do with it. It's some other smart people are doing it.
So
I guess I'll share. Here, go ahead, and I'll share these slides. Watch you guys.
And we have a couple more questions.
Yeah. Come, happy.
Hello, it's me again. I
Yes,
have a
hi.
question about brain and the gut connection too, because I've been hearing about a lot about this too. Something that you mentioned, I have read it in the Nemetschek protocol. I don't know if you are aware
Mhm.
of that. It's not scientifically proven yet, right? Or is it?
So there's pieces of it. I think when we have staggering numbers like we do of autism, it's very, a lot of people are publishing things. Like I said,
What,
I
what do you
always trust before verifying. Go ahead.
What do you think about this? I mean, is something like what are you recommending? Like the gut health in children with autism? Like, for example, in the Nemetschek protocol, they recommend fish oil and DHA. I don't know how you say in English. It's um it's a prebiotic. It's not a probiotic, it's a prebiotic. I speak Spanish.
Ajá, prebiotic. Ajá.
Entonces, me he estado informando, he estado leyendo el libro, no lo he terminado. ¿Qué opina acerca o sea, sería algo que recomendaría el, el protocolo Nemetschek?
Mira, el suplemento de vitaminas mal no le va a hacer. Básicamente, si ya viene una deficiencia con la alimentación. Entonces, muchos niños no están comiendo, por ejemplo, pescados u otras fuentes de alimentación para los omega 3. Eso por mí no hay un problema. El prebiótico no sabemos mucha información. Sí, te digo, como mencioné, sí sabemos que hay una diferencia con la bacteria en algunos niños con autismo y que hay algún cambio con el hecho de probióticos. Aún no sabemos la cantidad y también el término probiótico es muy general. Hay bacterias específicas que se están viendo y buscando y eso es lo que estamos, partes del aprendizaje. Aún no estamos, digamos, a esto. Entonces, si es un protocolo de vitaminas,
Naturales, como que
mi única es que a veces son protocolos muy caros. Y mi experiencia ha sido que gente los hace, no tienen los resultados y se frustran más,
Ok.
¿verdad? Y no
¿Puede dar una
sabemos cuánto
recomendación
se
de
absorba.
algo que nos recomiende para los que estamos interesados en la salud de pues, los intestinos en los niños?
Pues lo más importante es un suplemento básico de algún multivitamínico si no están comiendo su requisito alimenticio al día, ¿verdad? El que le puedo yo decir, o sea, las vitaminas son una cosa, no puedo medir cómo el omega 3 está mejorando o empeorando. Mal, no creo que lo está haciendo. Qué bien o cómo medir qué bien va, no puedo medir eso. Aún no sabe, o sea, porque básicamente la teoría es de que este tipo de grasa está haciendo, en inglés se llama myelination, que es poniendo una capita de grasa en los nervios para que ese nervio funcione mejor. Tengo pacientes que nunca suplementan y mejoran, pacientes que suplementan han viajado por todo el mundo y no mejoran. Entonces, por eso digo, no les puedo decir, este es el protocolo. Y hay unos que han publicado protocolos, no juzgo de que en punto de hacer dinero o no. Unos son en base de la información, pero información que no aún se ha estudiado más allá. ¿Ok? Y eso lo veo mucho con mis pacientes con déficit de atención, ¿verdad? Acaba de haber un estudio de que muchas veces, oye, ¿qué hora de vitaminas para déficit de atención? Y acabo de leer un estudio de que aún con la vitamina no llega a mejorar como un estimulante, porque sabemos la diferencia. Tiene limitaciones. Entonces, la dosis es algo que el costo, lo que me preocupa, no le puedo decir qué dosis y el costo puede ser elevado. Y le digo, yo sí soy de probióticos, no le puedo decir qué probiótico y qué protocolo. Entonces, tengo pacientes que lo siguen. Si le quieren seguir, síguenlo y pueden observar, ¿verdad? Quizás le va muy bien, quizás no ve nada. Entonces, es difícil para dar un requerimiento que no hemos llegado, estamos en esas estudiando, ¿verdad?
Thank you.
Gracias.
Any other questions?
So this is sparked in accordance with just genetics. And this is a study that you can actually participate in being even in Eagle Pass. It's the centers at Texas Children's, and they can send you a kit. So it's elevating the research in genes and taking genetic samples from mom, dad, and child with autism with no cost and trying to figure out if there's a genetic relationship. And this is a study that's been going on, it's going on right now all over the country, okay, in different sites around the country. Really trying to get a lot of good information. And then let me find the information on the probiotic. Well, answer. Here we go. Go ahead. Oh, I see, Wendy. So this is let me see. So I don't know if you can see right here. This is the phone number in the lower left corner. I don't know if you guys can either maybe write it down if you like. Like I said, my understanding is that there is there might be on hold with the amount of kids that they are recruiting, but it's something that's going on. Okay, and in the chat, there's Daisy wrote, it also makes potty training extra difficult. You know, potty training is something that I think it's a source. Definitely, we have to talk about positive parenting, because there's readiness steps when you have to do potty train. Kids can control very limited things in their world. They can control two things: what goes in their mouth and what comes out of their body. And we see a lot of neurotypical kids, you know, that they might say, oh, they start peeing like a dog on the corner and they've been potty trained and I mean, there's a whole view. I see it all. When it comes to kids with autism, again, I really defer to, if they're not an ABA, they can figure out where are they in terms of their communication and understanding in terms of potty training. And how can we figure out, is it a coordination issue? Is it a communication issue? Is it sometimes they maybe went to a restroom and heard the toilet flush and it scared the heck out of them, and they're like, I don't do toilets, they scare me. So there's all these different layers. OTs will talk about feeling supported. They might feel that they're dangling on a toilet seat, they're not going to fall off. So how are they going to go to the restroom? It's like say, go to the restroom in an airplane that has turbulence. Are you going to go? I mean, you might, but are you going to feel comfortable with everything moving around and you not being secure? So all those things that take into account when it comes to potty training. So yeah, it is a complicated topic, and that's why a multidisciplinary approach with ABA and OT and speech really helps with that.
Thank you for sharing that. And I think that that's a critical resource too for us, especially in Eagle Pass, to be able to be a part of these studies, because it's free access to care that we can access and really help improve the field of science for everybody to understand disabilities better and how our how things work. So it's a great resource for us to use. So thank you for providing that to us. So Dr. Anzueto, we thank you from the bottom of our hearts here in Eagle Pass. Let's give him a round of applause. So
Thank you so much.
We're so thankful to have you, and thank you for joining us in such a busy week, and thank you for your hard work and dedication, and we hope to see you here soon in Eagle Pass.
Thank you. Hope you invite me again. I'll be happy, and thank you, Wendy and Cole Health, for the opportunity. And it's a journey that we all have to take together, and we're happy to be partners with you in this journey. And we do things for safety. I hesitate because at the end of the day, I want them to be safe. I've seen kids in the ER with bleeds in their GI intestine because they were going through protocols of cleansing themselves of metals, and now having to have an operation take their colon out. And that's a whole other issue. So safety is the biggest thing. And I understand the desperation and the need to work. You guys are good parents and caregivers wanting to find solutions, and we're going to get there. We're going to do things little by little.
Thank you so much, Dr. Anzueto. Have a beautiful, cold, rainy weekend in Washington, D.C.
Thank you.
We'll keep it hot and warm here in Eagle Pass for you. Thank you.
Wonderful. Okay, have a good one. Thank you so much,
Bye.
everyone. Bye.